Let's start off our discussion by answering some of the questions posted by our participants. So we will address these questions to our lecturers and our panelists as well. So the first question is from Herlin Lydia. What is an effective way to develop a pre-hospital primary care system? Because in their country, it was not mentioned which country, the handling of trauma at pre-hospital or primary care is inadequate, and the patients do not get the right treatment late. Professor Stein?
Thank you for that. I think that there's no doubt that the most effective way to develop a pre-hospital care system is to train people. You can do with relatively little cost. A lot of people can be trained, and it's basic trauma care, advanced, the HLS, the NTMC, all of those courses would make a big difference. And by training people, it starts off, they may not have all the equipment, but by training them, you will stimulate them to acquire equipment, and it's basic equipment that is needed for basic early trauma care. And it also encourages them to set up the communication systems and to activate for their referral hospitals to be more available. So training is your first step, and it will be hugely valuable while you start from the top down. So I say not only top down, start from the bottom up as well. Thank you.
Thank you, Professor Stein. Professor Yao?
Yeah, I think I can only speak from the Singapore context, so please take it with that thing in mind. We are helped very much by our military, actually, because we have a conscript military service in Singapore, and most of our conscripts have to go in for about 2.5 years, and that's all the men. And so I think it's one example. I was thinking of what the last speaker said. It's one example of how you marry military and civilian assets, because under the military, there is a huge need to maintain a certain number of combat medics. And these combat medics, we find, make excellent paramedics. And so a ready-made manpower with not that much upgrading can be obtained from the military as a marriage of two sets of assets. So that's number one. Number two, I've seen this in other countries, not in Singapore. In part of your trauma dispatch system, it might be useful to actually distinguish paramedics services. So you get your standard ambulances where it doesn't really matter whether or not the senior man in the van is trauma trained, but then you get your trauma ambulances where you know that he's going to be dispatched to a major trauma case, because it's good to train. It's easier. It's possible to train, but having a ramp up service so that you distinguish, your dispatcher distinguishes what kind of ambulance should be sent. That's very useful as well. And again, in the military, we would do that as well. In the military, as you know, we have different fast teams, whether it's heli casevac or whether it's land casevac, we have different capabilities for inter-service transfer. So those are just my two thoughts. One is, there are very few people better at pre-hospital transportation of severely injured patients than the military. And so taking a page from their book, it might be a useful thing.
Can I just make a comment too? If anybody's interested, all of the clinical practice guidelines that the US government has supplied is open access for free. So if anybody is interested in what we have said, it's all available if you just Google Joint Trauma System Clinical Practice Guidelines.
Thank you, Dr. Worlton. Dr. Rizal, any comments for that question?
I think I know where the question comes from because I lived in that country for 7 years, which is not my country. I think we should get the input from Dr. Ahmad Hidayat as well. I think he's on board there somewhere. I think he would be a good person to answer the question. So there are basically a few systems that I've seen. Usually in more developed countries, you tend to have pre-hospital providers, which are free hospital providers. That means they are just doing pre-hospital care. Australia, New Zealand has the same way. You can have it as part of civil defense, and you can have it serviced by the St. John's ambulance, and there are many other ways that you can get to do this. Another way is, of course, in my country, is that the service is embedded into the Ministry of Health, I suppose. It makes it look as if it's like a huge monster who's a demagogue and wants to control everything. But that's how we are. So the pre-hospital services are provided by the ministry as well, which is not that desirable, I can say so. But it works. So it depends on the country that you are from, and to see what works for you. And that's why I've suggested Dr. Ahmad Hidayat there to give a few comments, because I think it comes from his country, and there are a few inherent problems of establishing a pre-hospital service in that country. But that country perhaps mimics mine in a way, that the public system can provide for it, but it has to be done with a lot of political will and a lot of financial support to provide for such a system. It may not be efficient to have that. So that's my take on it.
How about Dr. Ranjit?
Yeah, and as one of the few people who led the first ambulance service in Colombo, when there was nothing, let me talk actually, and how we developed. And it was led by anesthetist, and I supported wholly actually with a few people got together. We realized the need of it. Second, we realized that who is going to be trained. So there were 20 young people who were involved in the fire brigade. They were very young. They were very, they were listening to us, and they were trained fully. And then we had a little bit of support from the Municipal Council, Colombo. And with a lot of training and hard work, we managed to establish the first one in 2004. Then people realized the need of it. Unfortunately, it couldn't survive because there was no financial support, and but that was a good actually the way we started. So if you want to start something, you need a little bit of finance and people who are supporting you, authorities, and people who have been trained actually. Then after that, now the conditions are much better, and we have the huge fleet. And but if you want to do that, actually you gather people actually and then train them. First thing is to train, and then get the little bit of equipment to start with, and go on improving it. And as the time goes, I think everyone will realize the need of it and how we are going to improve.
Okay, thank you.
Yeah.
Yeah.
Elmi?
Yeah, I just want to remind people that pre-hospital system is not just the ambulance. It is when every country has little clinics and GP rooms and places that are not trauma centers, but that's where the injured patient is going to land up. And it's very important that we empower those medical staff to deal with the immediately life-threatening problems while they wait for the ambulance, because that ambulance won't be there. The ambulance has to be dispatched, called. So, the ambulance is not a place for treatment. So pre-hospital system is great if you're talking about transferring the patient, but the pre-hospital system is where the initial care is given, and then there's a transport, and then there's hopefully maintaining the level of care in the during transport, and then there's definitive treatment. So pre-hospital care is teaching every single doctor and clinic nurse in a country to look at airway, breathing, and circulation and stop bleeding. Then we're winning if we do that.
I think Dr. Stan made a very relevant point that pre-hospital care is not only ambulances, it is the whole gamut of other things of primary care. We need to educate and we need to empower those primary care physicians, nurses, rural health workers, where the patient will land first. Not only that, we had one of the studies from India that if you really improve pre-hospital care only, and you don't improve the emergency rooms in the tertiary care hospitals, and the doctors there are not educated and do not know, so you'll be just transferring those deaths from maybe the roadside or within the ambulance to the hospitals. So I think there has to be some amount of dovetailing into the training also. There has to be some amount of parallel, sort of growth of both the in-hospital acute care systems as well as the ambulances. Otherwise, you will have dead patients in the emergency rooms rather than on the roads. Very well said, ma'am. Any other question, Dr. Aireen?
Can I make a comment in this pre-hospital
Sure.
care?
Yep.
I have to say this because this is the international meeting and this is the best place to tell my story. When I finished my training in surgery and trained abroad, I went back and realized that as a trained trauma surgeon, I needed the ER to save the patient for them to get to my operating room so I can cut them up. Also, when I did that, so I developed the emergency medicine program in the university. And then I realized I also needed to develop a pre-hospital system. So I trained a lot of people to become personnel. Guess what happened? Singapore hired my emergency physician. The Middle East hired all my pre-hospital care people. Guess what? Today we still don't have a working emergency medical system. So we are all interconnected in this world. Somehow we need to talk in this particular venue because whatever I do in my country may also another country's needs may affect it, because Filipino nurses get hired abroad, EMTs get hired abroad. So I cannot compete with the pay scale of the richer countries paying my physicians that I train. So, and I trained them for the Philippines for my trauma system. Sorry to travail someone old.
Very well said. In fact, you actually said what I was about to say about the manpower training. Same happens with Indian nurses. 50% are either Filipinos or Indian nurses. But yes, we need to continue to train them. We have no other option but to continue to train them and probably give better healthcare systems worldwide, not only ours.
If I may, in my defense,
yeah.
No accusation. It's a global thing. I mean,
no. I wish to raise a point. We can't stop them from coming to Singapore because the food's just better, But I do have an interest in global surgery initiatives, and a partial solution to this was found when I visited Papua New Guinea. And as you know, PNG's healthcare system is integrated very closely with Australia's. And very often the certification is recognized across both states, and they have a very significant brain drain. The healthcare needs for trauma and general surgery in PNG are largely rural, where 90% of the population is found. And outside of Port Moresby, the capital, they have training for surgeons and not anesthetists, because anesthetists are even harder to train than surgeons. But the certification is only valid for that rural area. And very often when I was operating in PNG, the anesthetist wasn't a doctor. It was a big shock to me. He knew how to give 4 GA procedures and nothing else. But the point I'm making is that you can alter your certification process so that you can get your needs met without having a brain drain. There will be those in Port Moresby who will get the certification, will work in the UK, Australia, and Singapore. But there's a large number who actually have a burden to stay rural. And if given that option, they will stay. And it's a program that's worked very nicely for PNG. But I can't stop people from coming to Singapore. I mean, have you seen our food? It's just
incredible. I think Dr. Lau is becoming hypoglycemic now. Anyway, I think it's been a great session. Any more questions, Aireen?
Sir, these are more or less comments from our participants on regarding the Sri Lankan trauma system. So Dr. Ranjit, can you comment on these comments from our participants?
Right.
The chat box.
I think they are very valid comments actually. And motor traffic accident, we also feel that the number of three-wheelers or tuk-tuk and number of motorcycles are immense. And if one day we can reduce the number, at least we can reduce some of the fatalities, because most commonest people who are vulnerable is pedestrians, motorcyclists. They are very young and driving very fast and erratic. And three-wheelers are it's not a vehicle at all, you know. If even the motorcycle hits three-wheeler, it's bent and injured all the people. But when some of the three-wheelers, the tuk-tuk carry about 5-6 people. This is because of the financial burden people have actually, and the common mode of transport from A to B. And if those could be improved, I think some of the mortalities could be reduced. And what also the road rules and regulations, and those are some of the things. And also consumption of alcohol. Now they have been detected all the roads in the night, and alcohol. So I certainly think that the valid points there. And
Thank you, Dr. Ranjit. I think you made very valid points about injury prevention as a part of the systems issues in trauma.